Hello and welcome to part 3 of this series of videos expanding on the core low-intensity CBT interventions that PWPs use with their patients. My name is Josh Cable, and over the last 7 years I've worked in a variety of roles within IAPT, including as a PWP, supervisor PWP, Step 2 lead, and more recently as a lecturer on PWP training programs at a number of high-profile UK universities. I created these videos as tools to support PWP's understanding of the core Step 2 interventions. This is not intended to replace your university training, but supplement your understanding in an easy to digest format. Today we're focusing on graded exposure, a CBT-based treatment for anxiety. Specifically, PWPs would use graded exposure to treat avoidance in the context of specific phobia and panic with agoraphobia. There's also an adapted form of exposure that qualified PWPs can use to treat OCD, called ERP, but this is for another video. In a nutshell, graded exposure claims that by exposing ourselves to things that cause us anxiety, over time the anxiety these objects or situations produce will start to decrease. The first step of any treatment intervention should be psychoeducation. What you're doing here is supporting the patient to understand the symptoms they're currently experiencing. I think that good treatment psychoeducation should always contain 2 elements. 1, why the patient is feeling this way, and more importantly, why the symptoms aren't going away on their own. This is where the ABC model and vicious cycle that we'll discuss shortly come in. 2, how we're going to support the patient to break their cycle. In essence, this is your rationale for how treatment will work. So let's start with that first bit, why the patient is feeling this way. At assessment, you should have given the patient an overview of CBT and the ABC model, but it's worth briefly going back over this now, as it may have been a number of weeks or even months since the patient's assessment. I won't go into a generic introduction to CBT today, as this would be the same across all interventions, but this should lead into a discussion of the ABC model. Within this discussion, you need to support the patient in understanding which of their symptoms go into which part of the model, and also how those areas are linked together. And you can see that a patient is doing this now. It's more collaborative to elicit these core symptoms from the patient rather than telling them what was said at assessment, and make sure you allow the patient to explore which area of the model each symptom should fit into. As with my previous videos, I've used the ABC model here, as this is what I teach my students. If you've been trained to use the 5 areas model, then all you need to do is also get the patient to write in their trigger and corresponding emotion. Whilst any patient engaging in CBT-based treatment needs to understand that their symptoms are linked together, for graded exposure it's particularly important for patients to understand specifically how avoidance maintains their anxiety. Avoidance is a common strategy used to manage anxiety. It's a human instinct to avoid things that make us feel unpleasant in any way. For example, if I touch the desk in front of me and I feel a pain in my finger, my natural instinct will be to pull my hand away and then not touch the desk again. This is the same as with anxiety. When something makes us feel anxious, our instinct is to get away from it and avoid it in the future. In some circumstances, avoidance does not have a significant impact on our life, and it can actually keep us safe. For instance, avoiding driving 100 miles an hour because of a fear of crashing. However, avoidance of objects or situations that we encounter on a frequent or even daily basis, so it might be busy shops, lifts, driving, can all have a significant impact on our lives, and it's in these cases that graded exposure can be helpful. This is an example of a vicious cycle, the model through which cognitive behavioural therapy explains what is maintaining the mental health issue. Here you can see how avoidance of situations maintains our anxiety, and you should talk through this model with the patient within your sessions. Remember to include the patient's symptoms in this model to be more collaborative. Looking at this example, if we start at the top we have the trigger, which is the thing that the patient fears, in this case it's spiders. As a result of interacting with this trigger, the patient worries that something bad will happen. This could be the fear of being hurt or dying, or it could be something else like embarrassing themselves. In our spider example, the fear could be that the spider will hurt them. As a result of being exposed to the feared stimulus and the thought that follows, the patient feels the physical symptoms of anxiety that are associated with the fight or flight response. I don't have time to go further into fight or flight today, but in a future video focusing on panic attacks we will explore this further. Because of these scary thoughts and unpleasant physical symptoms, the patient avoids the triggering object or situation. So in this case, it might be that the patient runs out of the room when they see a spider, or they refuse to go into places where they think there may be spiders present. The next step of the cycle is what we call negative reinforcement. If you avoid something that causes you anxiety or that you don't want to do, the immediate feeling you have will be positive, be that relief, happiness, or a reduction in anxiety. Think back to a time when you had to do something you didn't want to do. It could be something at work, a chore at home, or even seeing a friend when you really couldn't be bothered that day. If you later found out that you didn't have to do that activity, you probably felt a sense of relief and maybe happiness as a result of this. This is an example of negative reinforcement, the concept that we have a positive outcome from avoiding doing something. In this case, the patient avoids the spider, resulting in a short-term relief from their anxiety. Now, this is when we get to the important part. This is the crux of what is keeping the anxiety going. The problem with avoidance is that although it may feel nice in the short term, in the long term it's keeping our fear going. When we avoid something, what our brain is registering is that A, we avoided the situation or object, and B, we are safe. What it therefore concludes is that the two are causally linked. In other words, it's only because we avoided that we are safe. This strengthens the belief that we need to avoid similar situations or triggers in the future. This, combined with the negative reinforcement we just discussed, results in people getting stuck in cycles of avoidance. In this example, by avoiding spiders, the patient is reinforcing that spiders are dangerous, and that if they had not avoided, something bad would have definitely happened. We know that spiders in England are very rarely dangerous, but because the patient is always avoiding them, they can never prove themselves wrong. If they never expose themselves to spiders, they can never experience that they're not likely to be hurt by them. So, they avoid the spider, but then what do you think happens the next time they see a spider? Of course, they avoid again. Their brain says to them, well, you avoided last time and everything was fine. Why chance it now? Let's just avoid again. Why not just stick to what we know is safe? And that's how avoidance and anxiety is maintained, according to CBT. This discussion of the vicious cycle moves nicely into our rationale for the graded exposure intervention. But before you explain it, try to see if the patient can get there themselves. Ask a question like, based on what we've discussed, how do you think we would go about breaking this cycle? Hopefully the patient will get the answer, but if not, you can support them to understand that it's the avoidance that's keeping the cycle going. Therefore, if we target and gradually reduce the avoidance, the cycle will start to break down, and the patient will realise that the thing they're so scared of is not so dangerous at all. This is an example of how the CBT model works. We only need to target one area of the cycle, in this case the behaviour of avoidance, and if we can reduce this, we can break the whole of the vicious cycle down. Now the patient understands that avoidance is what's keeping their anxiety going, let's explore this further with them. Here we're going to look at the difference between avoidance and something called habituation. Habituation is the natural process whereby our anxiety or fear gradually decreases over time. This means that if our example patient sat in a room with a spider, they would likely feel very anxious at first, but over time their anxiety would automatically decrease. There are a number of theories around why habituation occurs, but largely they can be narrowed down into two camps. Firstly, from a physical standpoint, we know that when we enter the fight or flight response, our body floods our system with adrenaline. In order to stay in this heightened state, we need to keep producing this adrenaline. However, our body cannot do this indefinitely. The theory is that the reason our anxiety starts to decrease over time is because our bodies start to produce less adrenaline as time goes on. The other reason behind habituation is a more cognitive process. When we first enter a scary situation, we worry about all of the bad things that will happen. However, over time, this worry naturally diminishes. If we step into a room with a spider, we may think that it will bite us, but if we sit next to it for half an hour and it hasn't bitten us yet, we may believe in this worry slightly less. Either way, the result is that if we stay in this feared situation, our anxiety will decrease over time. A nice metaphor to use when describing this to your patient is that of swimming in the sea. If you've ever swam in the sea in England, you'll know how cold it is when you first jump in. But then after a while, your body starts to get used to the cold and you don't feel it as much. This is the same with habituation. You feel anxious at first, but over time your body gets used to the situation and it doesn't feel so unpleasant. Habituation is the opposite of avoidance. As we've already discussed, if you avoid, you get a short-term reduction in anxiety, but then the next time you experience the feared situation, you'll feel just as anxious. This graph, courtesy of the Reach Out Guide, shows how avoidance results in these peaks and troughs of anxiety, whereas habituation results in this nice reduction over time. You may have noticed that there's quite a lot of psychoeducation to get through with graded exposure, but it's important that this is done. Of all the interventions we offer as PWPs, graded exposure is potentially the most intimidating to patients. Imagine you might have been scared of something your whole life, and then this stranger tells you the only way to overcome it is to expose yourself to it. This could be quite a scary prospect, and so it's important that you conduct a thorough psychoeducation so that the patient is clear what they need to do, but also why they're doing it and how it works. You should also try to normalize their fear and stress that exposure is a gradual process that moves at the patient's pace. I know I got on and on about this, but you need to be collaborative in this psychoeducation. Especially with this intervention, it's so important that the patient feels part of the process, not like you're forcing them to do something they don't want to. To this end, make sure you're asking questions throughout your discussion of the rationale. Stay away from lecturing the patient. Remember also the importance of materials throughout your psychoeducation. There's a lot of information for the patient to take in, but this is easier if they have something to visually refer to. This is why I would suggest sending them a booklet on graded exposure before the treatment session. That way you can refer them to the ABC model and graphs as you discuss them. This will make it much more likely that the patient will understand what you were talking about the first time. If your service doesn't have these materials available, then the Exeter Cedar ones are very good. Now that the patient understands the rationale behind graded exposure, it's time to start working on exposure hierarchy. The purpose of creating a hierarchy is to help the patient to gradually build up to facing the thing they're most scared of. Creating a hierarchy allows us to break down their phobia into smaller but still anxiety-provoking activities. You should reinforce to the patient that this is a gradual process and that they'll not be exposing themselves to the thing they fear most straight away. You may want to discuss here the difference between graded exposure and flooding. Flooding was a commonly used practice for phobias in the 1960s and 70s, where someone was cured of their phobia by being straight away exposed to the thing they feared the most. For instance, someone who's scared of spiders could be locked in a room full of spiders. For some people this does work, however we now know that for most people this experience can be highly traumatic and actually cause more anxiety. This is why we gradually expose people to situations they fear instead, which allows them to gradually get used to the habituation process and build their confidence. The exposure hierarchy is relatively easy to fill out, but it's important the patient has a good understanding of this now, or they may struggle later in the intervention. It's a good idea to at least start constructing the hierarchy within your treatment session. From experience, the easiest way for the patient to work through this hierarchy is to start by putting their most feared situation at the very top. If we go back to our spider example, this might be to hold a spider in their hand. They would then rate how anxious that makes them feel, imagining they had to do it right now, with 0% being not at all anxious and 100% being the most anxious they've ever felt. In this case, you can see that the patient has rated this 90% anxiety provoking. They would then break this down into progressively easier steps. So I might say to the patient, if holding a spider is 90% anxiety, can you think of anything that would be slightly less anxiety provoking than that? They may say that having a spider sit on their lap would be 80% anxiety provoking. You would then support the patient to move down the hierarchy, creating steps that are slightly less anxiety provoking each time. These steps should come from the patient, with you asking guiding questions to support them. However, if they're really struggling, you could provide a firmer prompt. As a last resort, you could ask something like, if seeing a video of a spider is 55% anxiety, what percentage would seeing an image of the spider be? However, this is quite leading, so try to avoid this if you can. There are two very important considerations to keep in mind when creating an exposure hierarchy. One, the hierarchy should progress gradually. It will make the patient's life a lot harder later in the intervention if there are massive jumps between steps. Instead, try to support them so that there's no more than 10 to 15% anxiety jump between steps on the hierarchy. Number two, the hierarchy should only focus on one stimulus or feared situation or object. This means that if the patient has multiple things they're avoiding, these should be on separate hierarchies. For instance, this patient's hierarchy just focuses on exposing themselves to spiders, which is good. However, if they were also scared of heights, they would need to make a separate hierarchy focusing on this. They would not put anything to do with heights into this spider hierarchy. Once the patient is happy with how to complete the hierarchy, and you've discussed a few example steps, You would likely end the session and they would finish this for homework. The patient will likely come back with more steps than are shown here, but this is just to show you an example of what a completed hierarchy might look like. The next session, you would review the patient's hierarchy before moving on to the last bit of psychoeducation before they actually start doing exposure activities, the 4 conditions or rules of effective graded exposure. Following these 4 conditions will not only improve the chance of graded exposure working for the patient, but also make it an easier, less stressful process for them. Again, when discussing these conditions, remember to ask questions and refer to materials. You may ask questions like, why do you think it's important to stay in the situation? Or why might we not want to distract ourselves from the anxiety? As a quick side note, you may notice that in some materials the conditions are discussed before the hierarchy, and in some they're discussed after. Either way works, however my view is that doing the hierarchy earlier on in the process is beneficial as it gets the patient doing something practical. You also already alluded to the graded condition when introducing the hierarchy, and then the rest of the conditions are more relevant to actually doing the exposure exercises, so they fit quite well here. On to the conditions, the first one being graded. This should be easy to explore with the patient as you've already covered this when discussing why we complete a hierarchy. This condition ensures that we gradually expose ourselves to things that are more anxiety provoking rather than using flooding. In practical terms, this means gradually working up the hierarchy, not skipping steps or jumping ahead before the patient is ready or happy with the previous step. The next condition is prolonged. Remember how exposure works. In order for the habituation process to take place, the patient needs to remain in the situation. If they leave too early, they won't see the decrease in anxiety. They need to do everything they can to stay in that situation until they can recognize their anxiety is dropping. This is what will reinforce that the situation or object is not as dangerous as they feared. To do this, the patient needs to stay in the situation until their anxiety is half of what it was at the start of the exercise. For example, if I went into a room with a spider and my anxiety was at 90%, I should stay in the room until I feel my anxiety has dropped to 45%. This may take 20 minutes, 40 minutes, or over an hour. We just don't know. And this is why you cannot plan in advance how long an exposure exercise will take. It's important to get this across to the patient, as they may suggest that a good starting point is to stay with the spider for a short amount of time, say 5 or 10 minutes. But actually there's no point in doing this, as it would result in them feeling anxious, but they wouldn't start to see the habituation process take place. The next condition is repeated. This is a nice simple one. In order to achieve sustained habituation, we need to repeatedly expose ourselves to the same anxiety-provoking stimulus. Unfortunately, exposure does not work like magic, and the patient's fear isn't going to be cured by one exposure exercise. The general advice is that the patient should be repeating each step until the starting anxiety they feel is around 30 to 40%. At this point, they can likely move up the hierarchy without causing too much distress. Generally, we would suggest that the patient practices 4 to 5 exposure exercises per week. What should happen, as you can see in this graph, is that each subsequent exercise should result in a lesser starting anxiety and a quicker habituation process. The last condition is without distraction. It is a natural instinct to want to distract ourselves when feeling anxious, and this is often reinforced in the media. If you're nervous of flying, listen to music, for example. Whilst this can be helpful in acute anxiety situations, like when flying, this is not helpful in the case of phobias. This is because if the patient is distracted, they'll be unable to appreciate the habituation process taking place. In other words, if the patient is focusing on something else like listening to music, they won't be able to appreciate that their anxiety is dropping, even though they're still in the room with the spider. They need to sit with the anxiety in order to notice the habituation taking effect, and for the intervention to therefore start working. Sometimes the patient may have really ingrained safety behaviours, and so the first step of exposure might be just trying to reduce the patient's reliance on these, and then you would move on to a more traditional exposure hierarchy. By this point in treatment, you should have discussed the ABC model and vicious cycle of avoidance. This should then feed into the rationale for graded exposure. Next, you'll have introduced habituation and discussed how it's different to avoidance, then supported the patient to create an exposure hierarchy, before finally discussing the 4 conditions of graded exposure. Now the patient is ready to start conducting exposure exercises. The patient will use an exposure exercise sheet to support them with this, and you can see an example here. For the sake of clarity, I've taken out a number of the blank rows, but imagine if this had another 4 or 5 blank rows beneath it. Before the patient conducts exposure exercises, they need to be clear on how they can use this worksheet to plan and record what they are doing. The first column, date and time, is self-explanatory. When is the patient going to do the activity? The exercise column is where the patient records the exposure exercise that they are going to be doing. The patient should start by choosing the lowest activity from their hierarchy, which is still rated at 50% anxiety or above. The reason we don't get patients to conduct exercises which have less than 50% starting anxiety is twofold. For one, these activities are less likely to be having a significant impact on their lives because they cause less anxiety. And for two, it's harder to see the habituation process when an activity doesn't cause a massive amount of anxiety to start with. Therefore, if it's only 50% anxiety to start with, it's going to be harder for the patient to appreciate that that is decreasing over time. So the patient would look at their hierarchy and choose an activity that they rated at 50%, or the closest anxiety rating to this if they didn't rate anything at exactly 50%. In this case, you might remember that the patient rated seeing images of spiders at 40% and then hearing other people speak about spiders at 50%. Keeping the previously mentioned rule in mind, we wouldn't start with the images exercise as it doesn't produce at least 50% anxiety. In this case, we would start with the activity at 50% anxiety, which was hearing other people speak about spiders. The patient then writes their chosen exercise and before anxiety rating into the worksheet. This before rating is the patient's anxiety at the point of planning the task. These anxiety ratings are subjective to the patient, but that doesn't matter as long as they're consistent in their personal ratings. A good reference point is that 0 is no anxiety at all, and 100 is the most anxious they've ever felt. This is the planning phase done. When the patient gets to the planned time, they would do the exposure exercise and fill out the rest of the sheet. Imagine now that it's the 1st of January at 2 p.m. The patient would start their exercise. In this case, let's imagine that they've recruited their friends to speak about spiders in front of them. As soon as the exercise starts, they would rate how anxious they feel. In this example, you can see that the patient felt 80% anxiety here. Remember the prolonged condition. The patient needs to stay in the situation until their anxiety has dropped to half of the starting rating. In this case, they would stay in the situation until they felt their anxiety was around 40%. They would then, and only then, fill out the after exercise rating and duration columns. In this case, you can see that it took 45 minutes for the patient's anxiety to halve. Finally, the patient should be encouraged to write some comments into the final column. How did the exercise feel? Was it as scary as they feared? Did the feared consequence come true? Did they notice the habituation? Is it getting easier over time? Etc. Once the patient's happy with the exposure exercise worksheet, they would start conducting their exercises outside of your sessions. From this point onwards, you'd be using your sessions to support the patient to reflect on their exercises, consider when's a good time to move up the hierarchy, and help troubleshoot any barriers. Remember that the patient should move up the hierarchy once their starting anxiety is consistently around the 30 to 40% mark, and they've clearly noticed the habituation process taking place. The patient would continue conducting their 4 to 5 exercises a week, progressing up their hierarchy until discharge. One final thing to keep in mind with exposure therapy conducted at step 2 is that the patient may not reach the top of their hierarchy within your sessions. If anything, it's probably unlikely that this will happen, but that's completely fine and is to be expected. Remember the slightly cliche statement behind step 2 working. We're training someone to be their own therapist. Well, this makes perfect sense here. It's unnecessary for us to hold the patient's hand forever. They're ready for discharge when they're confident with how to conduct exposure. They can then go away from your sessions and work up the rest of the hierarchy on their own. We've now covered the full graded exposure intervention, but before we finish, let's summarise the key steps that we've discussed today. Step 1 is to discuss the ABC model and socialise the patient to CBT. Step 2 is the vicious cycle of avoidance and how to break this cycle. Step 3 is introducing the patient to the concept of habituation and how it's different to avoidance. Step 4 is supporting the patient to complete an exposure hierarchy. Step 5 is a discussion of the 4 conditions of exposure. Step 6 is for the patient to plan exposure activities, and then they do these activities in step 7, before finally reviewing their progress in step 8 and considering if it's time to go up to the next step in their hierarchy. The patient would then return to the planning stage and keep working through steps 6, 7 and 8 until discharge. You'll end your last session with some form of relapse prevention, but that's for another video. I hope that this video has helped develop your knowledge of the graded exposure intervention and will assist you in treating patients with specific phobia and agoraphobia in your clinical practice. If you're interested in other videos like this, then you should watch the rest of this video series, focusing on behaviour activation, cognitive restructuring, worry management and more. Thank you for watching, and I hope you have a nice rest of your day.